Welcome back to the Deep Dive. Today we are taking on, well, one of the most dynamic and frankly critical fields in medicine,
Yeah.
pediatric orthopedics.
It's a huge topic.
Yeah.
And it's so rewarding, but it presents these really unique challenges. When you're dealing with a child's skeleton, you're not managing a fixed structure.
Right, it's not a static thing.
Not at all. You are managing a living, growing system. It's like a biological construction site where the blueprints are constantly being updated.
And the core conflict, I guess, is navigating that incredible capacity a child's skeleton has for remodeling and healing.
And fast healing at that.
While understanding that if you mismanage the growth plates, you can lock in, well, progressive, lifelong deformity.
That's the tightrope walk, and that's what we're here to understand.
Absolutely. This deep dive is comprehensive. It's designed specifically to help you thoroughly revise and, instantly recall the whole spectrum of conditions, from those benign physiological variants that you just leave alone to the catastrophic surgical emergencies.
Our mission is to equip you with that necessary foundational and clinical knowledge. We'll be focusing particularly on the crucial hip triad.
Developmental dysplasia of the hip, Perthes disease, and slipped capital femoral epiphysis.
Exactly. Alongside the critical infections and, of course, the non-accidental injuries we just must never miss.
So before we even look at a single condition, we have to establish the two sort of iron laws that govern bone growth.
Yes. If you can get your head around these two principles, you really understand the fundamental mechanics of the entire field.
Okay, let's unpack this with the first law, the Hütter-Volkmann principle.
So this one is fundamental. It defined how growth plates react to pressure. Specifically, compressive forces inhibit growth.
They slow it down.
They slow it down,
Yeah.
while tensile forces, pulling forces, they stimulate it.
Okay, so give us a practical example. How does that work?
Well, think of it this way. If a child has a deformity, say one side of a bone is growing too fast, we can surgically restrict that side, apply controlled compression, and the other side, which is experiencing relative tension, it catches up.
That's fascinating. You're essentially creating a temporary controlled deformity to force a correction.
You're literally using the child's own remaining growth potential as your corrective tool.
And this principle, it must tie directly into the bone's ability to adapt its overall structure, which I guess brings us to Wolff's Law.
Wolff's Law is the macro-level view of that. It dictates that bone deposition and resorption are entirely dependent on the mechanical stresses you apply to it.
The old form follows function idea.
Precisely. Bone strengthens where it is loaded, and it resorbs where it isn't.
So what does this mean in practice, say, for a developing joint like the hip?
Okay, take the hip. If the femoral head is correctly seated in the acetabulum, that constant cyclical pressure, that compression, stimulates the acetabulum to deepen and develop properly.
It tells the socket to grow around the ball.
It does. But if the hip is dislocated, as you see in DDH, the acetabulum receives no mechanical stress, so it just remains shallow or dysplastic.
Right.
But the second we successfully reduce that femoral head back into the socket, the return of that normal pressure immediately stimulates the bone cells to start depositing matrix, and it remodels that acetabulum naturally.
So these two laws, working together, they explain why early intervention in pediatrics is so non-negotiable.
Absolutely. We have to reestablish the correct mechanical environment while that remodeling engine is still running at full throttle.
Since we're talking about construction, let's go right back to the blueprint stage. Embryology. It's wild to me that limb development is one of the most rapid, specialized processes in the entire body.
It really is. It occurs in an incredibly tight window, spanning just 4 to 8 weeks after fertilization.
Wow, that's fast.
It is, and this narrow time frame is critical because if there's any insult, a genetic mutation, a teratogen, a vascular event during this period, that's when most major congenital limb anomalies arise.
And it's all managed by a signaling system.
A highly precise system of 3 coordinated signaling centers. You can think of them as the quality control management for the developing limb bud.
Okay, first up, the apical ectodermal ridge, or the AER.
So the AER is the master control for proximal to distal differentiation. It controls whether you grow a shoulder, then an elbow, then a wrist, and so on. It functions via fibroblast growth factors, or FGFs.
And there's a really clear example of its function.
A very clear one.
Yeah.
Experimental removal of the AER immediately leads to a truncated limb, a spontaneous stop in development, which, it mirrors a congenital amputation in a human.
But here's where it gets really interesting for me. The AER's job is also to facilitate the death of tissue between the digits to create fingers and toes.
Exactly. If that control is disrupted, you don't get the necessary programmed cell death or necrosis between the digits.
Which leads directly to syndactyly.
Webbed digits. It's a beautifully balanced system where both growth promotion and program destruction must occur perfectly.
Okay, so next, directing the side-to-side structure, we have the zone of polarizing activity, the ZPA.
The ZPA manages anterior to posterior development. It determines the site of the limb, and it utilizes the sonic hedgehog protein.
So it makes sure your thumb is on one side and your pinky is on the other.
That's its job. And the classic experimental outcome if you introduce an extra ZPA is remarkable. You get a mirror duplication of the distal limb, so essentially an extra pinky and ring finger mirroring the existing structure.
And finally, anchoring the orientation, we have the Wnt signaling center.
That influences the dorsal to ventral axis, so the palm up, palm down orientation of the limb.
The sobering takeaway here seems to be that because these signals are systemic, an insult that affects the limb formation often affects other vital organ systems that are developing at the same time.
That's a critical point. An orthopedic anomaly is not just an isolated structural defect, it can be the tip of a much larger iceberg. The source material really emphasizes this connection, that fetal limb anomalies often prompt investigation for potentially life-threatening systemic disorders, like those you see with the Vacteral syndrome complex.
Vertebral, anal, cardiac, tracheoesophageal, renal, and limb defects.
The full set. So finding a congenital limb anomaly should be an immediate prompt for a complete systemic workup.
Okay, we've seen how precise the initial building blocks are. Now let's talk about what happens when parents come in worried that the structure isn't growing quite right, often concerning things that are actually, well, perfectly normal.
The general rule here is our first clinical filter, and it's a simple one. If a gait or alignment variant is symmetrical, completely symptom-free, and the child is otherwise meeting their developmental milestones,
You leave it alone.
you leave it alone. Intervention is typically not required. Observation is the management. We only start to investigate if there's asymmetry, pain, or functional impairment.
And the most frequent parental concern is probably in-toeing gait or a negative foot progression angle. It's so vital to trace where that rotational problem is actually coming from.
Yes, the problem can originate at 3 different levels, and parents often confuse them. So, starting at the hip, we find persistent femoral neck anteversion. The femoral neck, compared to the shaft, is rotated forward, which causes the entire leg to turn in.
And how do you clinically assess that? What do you look for?
You assess the range of motion, so these children, when they're lying prone, will show excessive internal rotation at the hip, often 80 or 90 degrees, but severely limited external rotation.
The classic W-sitting child.
That's the one! This is primarily a physiological issue that spontaneously improves with growth as the neck derotates relative to the shaft.
So we counsel the parents to wait, unless the child is, say, 10 or 12 and still tripping over their own feet.
Exactly. A corrective osteotomy is really reserved for the rare, persistent, and functionally debilitating case beyond that age, 10 to 12.
And there's an interesting detail here about a specific syndrome.
Yes, the miserable malalignment syndrome. This is where a child has pathological femoral anteversion, but the body tries to compensate for it lower down with an external tibial torsion.
So the foot looks like it's pointing straight ahead.
The foot progression angle looks normal, but the rotational forces through the knee and the patellofemoral joint are all wrong, which often leads to knee pain and instability later in adolescence.
Okay, moving down the leg, the next common cause is internal tibial torsion.
So this is a twist in the shin bone itself. We assess this with the thigh-foot angle. It's extremely common in infants, often associated with physiological tibia vara or bull legs, just because of how they were positioned in utero.
And it corrects itself.
The correction is nearly universal and spontaneous. It typically resolves by age 4 as the child starts bearing weight and walking properly.
And the final level, the foot itself.
Yeah.
Metatarsus adductus.
This is the forefoot being adducted or turned in relative to the hindfoot. It gives it that characteristic bean shape. Like the others, it's usually flexible and corrects by age 2 to 4.
And what if it's rigid?
For the rare rigid feet that don't stretch out, serial plaster casts or maybe specialized shoes might be used, but surgical release is exceptionally rare. The really conservative nature of management across all 3 of these conditions just highlights the incredible power of pediatric remodeling.
Let's talk about the alignment of the legs themselves. Bow legs, varus, and knock knees, valgus. The knee alignment follows this, like, predictable curve of development.
It's a standard progression. All children are born slightly bow-legged, so varus. This peaks at around 6 to 12 months.
Okay.
They then gradually transition through a neutral alignment and develop knock knees, or valgus, by age 2 to 3. This valgus then gradually reduces until it reaches the normal adult angle of about 7 degrees valgus by age 7.
So if a parent brings in a 3-year-old with knock knees, our job is to tell them that's exactly where they should be developmentally.
Precisely. We only investigate with radiographs, measuring intercondylar or intermalleolar distance, if the deformity is severe asymmetrical, or if the child is outside that expected age range. Pathological causes, things like trauma, rickets, or skeletal dysplasia, must always be excluded in those specific outlier cases.
Finally, the ubiquitous flatfoot concern.
Yeah.
I think every single parent has asked about this at some point.
And rightly so, because every single young child under the age of 3 has flat feet. That's thanks to a protective fat pad that obscures the arch and physiological ligamentous laxity.
The distinction is key, though. Is it flexible or rigid?
Yes. The painless, flexible flat foot is overwhelmingly the norm. How do we test it? It's simple. When the child stands on tiptoe, the arch returns and the heel corrects from valgus into varus.
Right.
If you can passively move the subtalar joint fully and painlessly, it's fine.
So what's our message on orthoses or shoe inserts for flexible flat feet? Because people spend a lot of money on these.
The evidence is very clear. Orthoses do not alter the natural history. They do not fix or create an arch. They can alleviate symptoms if the child is experiencing some mild ache from tired muscles, but they are generally unnecessary.
The real danger is the rigid flat foot.
That's what we look for. The arch fails to return on tiptoe, the heel stays rigidly in valgus, and the subtalar joint movements are restricted and often painful.
And when you see that, you have to investigate.
You must investigate it. For inflammation, or most commonly a structural issue like a tarsal coalition, a bar of bone or cartilage joining 2 tarsal bones together, that's something that requires management.
To wrap up these variants, let's quickly address toe walking.
For a young child just learning to walk, toe walking is a normal phase of gait. If it persists past age 3, physiotherapy is standard.
But there's a critical red flag.
There is. It's late onset toe walking. If a child walks normally for years and then suddenly starts walking on their toes, that demands immediate exclusion of serious spinal or neuromuscular pathology.
Like what?
A tethered cord, early-stage muscular dystrophy, or even an orthopedic cause like an undiagnosed unilateral dislocated hip, which is causing a functional short leg.
Okay, let's move from those variants to true congenital malformations. The source material provides some key visual red flags that should alert the clinician to a complex underlying syndrome.
Yeah, these are subtle cues that the initial insult wasn't just, mechanical. You need to look for a skin dimple or a vascular malformation over the spine or a limb.
Because that could indicate something deeper.
It could. These can indicate underlying spinal dysraphism or other complex congenital anomalies. Also, the presence of featureless limbs should prompt deeper investigation. You often see this in conditions like arthrogryposis multiplex congita or AMC, where you have multiple joint contractures present at birth.
The classification of these limb malformations, failure of formation, duplication, overgrowth, is pretty systematic. But I want to focus on the management philosophy for the really complex cases. Let's use proximal femoral focal deficiency, or PFFD, as our example.
PFFD is a great example. It's a severe longitudinal deficiency of the femur. It's incredibly challenging because you're dealing with a short, unstable limb, often with associated foot and hip abnormalities.
And the management involves a really difficult choice.
It does. It's extensive, multi-staged limb reconstruction. So attempting to lengthen and stabilize the femur versus amputation and the use of a sophisticated prosthesis.
And the source material highlights that despite the allure of advanced surgical reconstruction, the patient outcomes aren't always superior.
That is the crucial caveat. While reconstruction sounds ideal, the PROMs, the patient-reported outcome measures, they don't consistently show superiority over the functional advancements in modern prosthetics.
So what's the bottom line for the clinician?
You have to balance the years of surgery and potential complications against the functional and cosmetic needs, and acknowledge that in some severe cases, a definitive amputation might offer a better long-term quality of life and mobility.
Okay, let's dive into the generalized skeletal dysplasias, where the genetic code dictates faulty bone development. First, achondroplasia.
Achondroplasia is the most common form of dwarfism. It's an autosomal dominant condition, usually a gain-in-function mutation in the FGFR3 gene. The core pathology is a failure of enchondral bone formation.
Which is the process of cartilage turning into bone.
Right, the process that lengthens the long bones and the spine.
This results in that classic physical presentation.
Yes, disproportionate short stature, so the limbs are much shorter than the trunk. And you see specific radiographic findings. Short long bones, widened metaphyses, and distinct features in the pelvis, like square pelvic wings and a horizontal acetabulum.
But the complications are the real clinical concern.
They are. The underdevelopment of the base of the skull, particularly the foramen magnum and the subsequent spinal stenosis, these pose major neurological risks that have to be monitored throughout the child's life.
Okay, next up, hereditary multiple exostoses.
Again, autosomal dominant, but this time it's a loss of function mutation in EXT1 or EXT2. This leads to dysregulated growth and the formation of multiple osteochondromas.
Which are benign, cartilage-capped bony outgrowths.
Exactly. They usually grow away from the joint, but they can cause functional issues by pressing on nerves, tendons, or blood vessels, or by causing an angular deformity due to differential growth.
And the primary management here is preventive and symptomatic.
Yes, we excise them when they cause problems. But the key detail for you to remember for revision is the malignant potential. Continued growth of an osteochondroma after skeletal maturity is a major red flag.
Potentially indicating malignant transformation.
Into a chondrosarcoma, though it is rare.
Moving to All-Ears disease or enchondromatosis.
This involves multiple enchondromas, which are basically rests of chondrocytes, within the medullary canal of tubular bones, most commonly the hands and feet.
And they weaken the bone.
They consist of mature hyaline cartilage, and they significantly weaken the bone, so pathological fractures are a very common presentation. We also must remember its connection to Maffucci syndrome, where All-Ears disease is combined with soft tissue, hemangiomas, and lymphangiomas.
And finally, fibrous dysplasia.
This is where normal bone is replaced by a fibrous stroma due to a localized defect in osteoblastic differentiation. The monostotic or single bone form is often just an incidental finding on an X-ray.
But the polyostotic form is different.
Much more serious. The polyostotic or multiple bone form causes significant limb deformity and pathological fractures because of that weakened architecture.
But the association is what makes this diagnosis so memorable.
Absolutely. We link polyostotic fibrous dysplasia to McCune-Albright syndrome, which adds two striking non-skeletal features: precocious puberty and the classic irregular unilateral coast of Maine cafe au lait spots. When you see that triad, the diagnosis is confirmed.
Now we shift gears to metabolic bone diseases, starting with rickets, a problem of mineralization.
Rickets is fundamentally inadequate mineralization of the growth plate and the bone matrix. The growth plate cartilage, it continues to grow, but it fails to calcify properly, which leads to structural instability.
And the causes are really wide-ranging.
Very wide-ranging. Nutritional, so vitamin D or calcium deficiency. Environmental, lack of sunlight, malabsorption issues like Crohn's, or genetic, like X-linked hypophosphatemia.
When we look at an X-ray, what are the pathognomonic signs? What screams rickets?
The growing ends of the long bones look diseased. You see widened physes, the growth plates are thick and indistinct, and the metaphyses, the flared ends of the bone, look cupped and irregular.
And the management principle is crucial here.
It is. Medical management first. We have to stabilize the underlying metabolic disorder and get mineralization under control before we do anything else.
And the surgery follows that.
Yes. Once the bone is metabolically stable, we address the residual deformity, and the modern approach strongly favors guided growth techniques.
So using temporary compression on one side of the growth plate, Huter-Volkmann in action again.
Exactly. Rather than large invasive osteotomies, you allow the body to correct itself gradually.
The other major metabolic condition is osteogenesis imperfecta, OI, the brittle bone disease.
OI is a whole spectrum of conditions characterized by an abnormality in type I collagen production. Collagen is the scaffolding for the bone matrix, so if it's faulty, the bones break easily.
But they heal well.
They typically heal very promptly, which can sometimes prompt suspicion of non-accidental injury if the history isn't clear.
And beyond the fractures, OI affects the entire collagen system.
Exactly. This leads to systemic features, generalized ligamentous laxity, often resulting in hypermobility, the classic blue sclerae in the eyes, and poor dentition or dentinogenesis imperfecta.
And what's the key medical treatment here?
Cyclical bisphosphonate treatment. This reduces bone resorption, increases bone density, and drastically reduces the fracture rate. It promotes mobility and a much better quality of life.
And for surgery,
When surgical stabilization is required for fractures or osteotomies, the technique really matters. Intramedullary rodding, so rods placed inside the bone, is preferred over plate fixation because it allows for continued growth while still providing internal stability.
We have reached the high-stakes portion of this deep dive, the triad of childhood hip abnormalities. These conditions are so frequently misdiagnosed or delayed, and they are the leading causes of early degenerative arthritis in young adults. Let's start with developmental dysplasia of the hip, DDH.
DDH is probably the most complex because it is a spectrum. It's not just a dislocated hip. It ranges from a shallow, inadequate acetabulum, that's dysplasia, to an unstable hip, one that's subluxatable,
Right.
to one that is fully dislocatable, and finally to an irreducible fixed dislocation.
And the clinical presentation is entirely dependent on the child's age, which is why screening is so critical. But let's review the crucial risk factors first.
Understanding the risk factors guides your screening. So DDH is 4 to 5 times more common in girls, largely due to maternal hormones causing temporary joint laxity. Breech presentation, especially extended breech, is a major factor because that position mechanically strains the hip.
And we see lateralization effects as well, don't we?
Yeah. We do. It's more common in the left hip and in firstborns. That's because the tight, primogravid uterus, combined with the normal fetal presentation, puts specific asymmetric forces on that left hip.
And you look for other signs?
We also look for associated postural deformities, like torticollis, a twisted neck, or metatarsus adductus, which signal that there were tight quarters in utero. The environmental context is also vital. Cultural practices that swaddle the baby's legs straight actually promote instability.
Whereas carrying the baby astride is protective.
Exactly. It maintains that flexion and abduction, which is protective.
Let's detail the age-dependent diagnosis, starting with the neonate.
So neonatal diagnosis, usually done at birth and then at 6 weeks, is clinical. We use the Barlow and Ortolani tests. The Barlow maneuver test for instability. Can the hip be pushed out of the socket? It's the dislocatability test.
In the Ortolani.
The Ortolani maneuver test for reducibility. Can the dislocated hip be reduced with a palpable soft clunk?
And if the hip is truly irreducible, the Ortolani test will be negative, and the main sign then is a limitation of abduction.
That's the subtlety, and that's why bilateral dislocations are so easily missed, because the limitation is symmetrical.
So what's the role of imaging?
By 4 to 6 weeks of age, if a child is deemed at risk, say, from a breech birth, we use ultrasound. Ultrasound is the gold standard for visualizing the cartilage anatomy and stability before the femoral head ossifies.
And then you switch to x-rays.
Once the femoral ossific nucleus appears, usually around 4 to 5 months, we switch to plain radiographs. On the X-ray, we use landmarks to assess the location of that nucleus.
Hilgenreiner's line and Perkins line.
Exactly. We draw Hilgenreiner's line, which is horizontal through the triradiate cartilage, and Perkins line, which is vertical from the edge of the acetabulum. In a normal hip, the femoral ossific nucleus should lie in the inner lower quadrant created by those lines.
The goal of management is a stable reduction, achieved without causing AVN.
And the first rule is patience. Most unstable neonatal hips will stabilize spontaneously by 6 weeks. If instability persists up to 4 to 6 months, we treat with a Pavlik harness.
Okay, tell us about the harness.
It maintains the hip in a position of controlled flexion and abduction, which promotes seating and remodeling. The Pavlik is favored because it allows active movement, whereas rigid splints carry a much higher risk of femoral nerve palsy and AVN due to excessive force.
And what's the cutoff for the harness? What if it fails?
If the harness fails, or if the child presents later, say, after 6 months, we move to a closed reduction under general anesthesia. We might need to release tight structures, like the psoas tendon or adductor muscles, to allow the head to seat.
And then it's held in a cast.
Once it's reduced, the position is maintained in a customized spica cast.
If the hip is irreducible or the child presents even later, open reduction is needed.
Yes. For older infants, around 6 to 24 months, we'll perform an open reduction, either medially or anteriorly, often requiring a capsulorrhaphy to tighten the capsule.
And for older children?
For children over 18 months or 2 years where the dysplasia is established, reduction alone isn't enough to satisfy Wolff's law. The socket is just too shallow. So we require bony surgery, a pelvic osteotomy, like the Salter or Dega procedure, to reorient the acetabulum, and sometimes a femoral derotation or shortening osteotomy.
And there's a critical surgical cutoff, right? You can't do this forever.
Absolutely not. The potential for the acetabulum to remodel diminishes sharply after age 4. Surgery is generally contraindicated for bilateral dislocations over 6 to 8 years and unilateral over 8 to 10 years because the risks of intervention often outweigh the poor prognosis.
And the complications.
Residual dysplasia is the primary long-term complication, leading straight to early osteoarthritis. But the worst outcome, of course, is AVN of the femoral head post-reduction, which leads to a lifelong trochanteric overgrowth and a permanent Trendelenburg limp.
Okay, now for Perthes' disease of vascular necrosis of the femoral head. This hits the slightly older child, predominantly boys, aged 4 to 7 years.
The key to understanding Perthes is realizing it's a self-limiting cyclical process, but a very dangerous one. It starts with an unknown insult leading to AVM, a loss of blood supply to the epiphysis.
And that dead bone collapses.
It collapses under weight-bearing stress. Then the body attempts repair. Revascularization, fragmentation, which is the most vulnerable phase, then reossification, and finally, regeneration.
The damage, the shape change, is locked in during that collapse and fragmentation phase.
Exactly. The head is at its weakest then, and if it collapses, it heals in a flat, deformed shape. Clinically, the child presents with an intermittent limp, pain that can be referred to the knee-Hilter's law again, and restricted hip movement, particularly abduction and internal rotation.
So how is management philosophy distinct from DDH?
Well, Perthes is self-limiting. Our job is to minimize the deformity while the healing process occurs naturally. We maintain range of motion and reduce pain, but crucially, the source material argues against prolonged non-weight bearing.
So no crutches or wheelchairs.
They're discouraged because they promote a detrimental flexion and adduction posture. The focus is on containment.
Explain containment for us.
Containment is the idea that if we can keep the soft, vulnerable femoral head seated deep within the acetabulum acts as a natural mold. It encourages the head to re-ossify into a more spherical shape.
And surgery can help with that.
Early surgical options like a varus derotation femoral osteotomy or an innominate osteotomy are containment strategies. They're designed to maximize the coverage of the femoral head by the acetabulum during that critical reossification phase.
And what if the head is already healed but deformed?
That requires salvage surgery later procedures like a valgus femoral osteotomy or a head-neck osteoplasty to correct the fixed deformity and improve function.
Our final hip triad member, SCFE, is a diagnosis of the adolescent growth spurt.
This is a stress fracture through the proximal femoral physis or growth plate. The epiphysis, the femoral head, slips posteriorly and medially relative to the neck. It's primarily seen in pubertal boys, often overweight.
Why then?
Because the increased mechanical stress, combined with hormonal changes that weaken the physial plate, makes that growth plate vulnerable. Endocrinopathies, particularly hypothyroidism, also increase the risk.
The clinical presentation is frequently a diagnostic trap.
It is the ultimate diagnostic trap. Due to Hilton's law, the pain is often referred to the knee, which leads to misdiagnosis and dangerous delays. On examination, the leg is classically short and externally rotated, and any attempt to flex the hip results in mandatory external rotation of the entire limb.
Classification is paramount here because it determines the level of emergency. How do we classify based on stability?
Loader's classification based on stability is key. A stable slip is when the patient can still bear weight. An unstable slip is when they cannot. This distinction is critical because an acute unstable SCFE is a surgical emergency.
Okay, why?
It's equivalent to a highly displaced intracapsular fracture of the femoral neck. The mechanical shearing forces, combined with potential vessel kinking, put the hip at extreme risk of AVN.
So if a patient presents with an acute unstable slip, what's the protocol?
They go to the operating room immediately. It should be within 24 hours of the injury. We must perform the fixation in situ, meaning where it slipped, without attempting forceful reduction.
Any forceful manipulation is dangerous.
It drastically increases the risk of AVN. A capsulotomy, opening the capsule, is often necessary to decompress the vessels. And fixation is achieved using a single screw, pinning the head to the neck.
Now, what about the chronic stable slips?
Those are also fixed in situ with a screw, which relieves pain and prevents further slipping. However, it does lock in a permanent mechanical deformity, which results in a restriction of internal rotation and flexion.
And for severe chronic slips?
They may require a secondary realignment osteotomy, usually intertrochanteric, to correct the deformity and address femoroacetabular impingement, or FAI, but that's after the growth plate closes.
One final crucial point: the risk of bilateral involvement.
It's high. high enough that prophylactic pinning of the contralateral asymptomatic hip is frequently indicated, especially in younger patients or those with underlying endocrinopathies. Preventing a subsequent slip on the other side is a major goal.
Let's move to the knee, often the site of traction injuries and developmental issues in adolescence, starting with osteochondritis dissecans, or OCD.
So OCD involves a localized area of subchondral bone and cartilage necrosis. It usually affects the lateral aspect of the medial femoral condyle. The severity depends on whether the fragment is still attached to the underlying bone.
So management varies.
It does. In younger children with attached fragments, activity modification often allows for spontaneous healing. Prognosis is generally better in children than adults. If the fragment is unstable or loose, it requires fixation or removal.
Two common causes of anterior knee pain in adolescents are Osgood-Schlatter disease and patellofemoral pain syndrome. They're often confused.
Osgood-Schlatter is a classic traction apophysitis. It's an overuse injury at the insertion of the patellar tendon onto the tibial tubercle. Diagnosis is purely clinical. Localized pain, tenderness, and swelling, all exacerbated by jumping or running.
And it gets better on its own.
The condition is self-limiting and resolves upon fusion of the apophysis. The cure is time and relative rest. Importantly, radiographs are generally unnecessary unless we're trying to exclude something more sinister.
And patellofemoral pain syndrome.
That's more general. It's often associated with a growth spurt, overuse, or poor quadriceps mechanics. The pain is exacerbated by prolonged knee flexion, like sitting in a cinema. Management is overwhelmingly conservative.
Physio.
Activity modification and rigorous physiotherapy aimed at strengthening the vastus medialis oblique, the VMO, to improve the tracking of the kneecap. Surgery is rare, reserved only for true maltracking or instability.
Now for a more severe failure of formation, fibular hemimelia.
This is a failure of the lateral column of the lower leg. The severity is graded, but clinically you see a short leg, external rotation deformity, often a ball and socket ankle joint, and sometimes absent lateral raise of the foot.
And management is complex.
Very. It depends entirely on the degree of shortening. Options range from simply using a shoe raise to extensive limb equalization and lengthening surgeries, or, in the most severe cases, amputation may offer the most functionally effective outcome with a custom prosthesis.
Blount's disease. This is pathological tibia vara, or bull legs. We need to distinguish it clearly from the physiological bull legs we discussed earlier.
So, physiological bull legs are symmetrical, and they spontaneously correct by age 2. Blount's disease, conversely, is progressive, often asymmetrical, and involves disordered growth only in the postermedial proximal tibial physis.
Which leads to a very specific look.
It results in a sharp proximal bowing of the tibia and severe in-toeing. This requires surgical intervention, specifically an osteotomy to correct the angle, combined with epiphysiodesis or guided growth to prevent recurrence.
And a condition often confused with Blount's is congenital pseudarthrosis of the tibia, or CPT.
CPT is rare, and the key distinguishing feature is the location of the bow. It's an anterolateral bow, not the posteromedial one of Blount's. It's also highly associated with neurofibromatosis in about 50% of cases.
And it doesn't heal well.
The main challenge is that the bone is incredibly reluctant to heal after a fracture. It often requires repeated, complex surgical attempts and long-term orthotic bracing to achieve and maintain union.
Clubfoot is one of the oldest described deformities. And yet management has been completely revolutionized by the Ponseti method.
CTEV is a fixed, complex, three-dimensional deformity. You have the hind foot stuck in equinus, so pointed down, and varus, inverted. The midfoot is adducted, and there's an apparent cavus, or high arch, that is actually the forefoot pronated relative to the hindfoot.
Oh, you have to differentiate it from a positional clubfoot.
Which is flexible and can be corrected manually. This is a fixed structure.
The pathology isn't just bony, it's soft tissue.
Exactly. The talonavicular joint is the epicenter of the problem. The navicular is subluxed and displaced medially on the talus. And crucially, the posterior and medial soft tissues, the ligaments, the tendon sheaths, are pathologically shortened and thickened. The calf muscles and the foot itself are intrinsically smaller.
So walk us through the Ponseti method. It's the treatment of choice for 95% of idiopathic cases, and it's a really elegant sequential process.
The Ponseti method relies on specific, gentle manipulation to stretch the contracted tissues, followed by serial casting over 5 to 7 weeks. The sequence is vital and systematic. CAV.
C for correction of the apparent cavus.
Right. That's done first by elevating the dropped first ray. Then A, abduction of the forefoot gradually to about 60 degrees. V, the correction of the hindfoot varus, occurs simultaneously with the abduction.
And the final element, E, equinus correction, is typically the hardest and the last step.
It is. And it often requires a percutaneous Achilles tenotomy, a small snip of the Achilles tendon performed under local anesthetic. It's then held in the final cast for 3 weeks to allow it to heal at a lengthened position.
And this whole process corrects the deformity with minimal scarring.
That's the beauty of it. But the success of Ponseti is entirely dependent on what happens next.
Maintenance is everything.
If you fail the maintenance phase, the foot will relapse thanks to the dynamic pull of the calf muscles. The corrected position must be maintained using a foot abduction orthosis, a brace worn full-time for 3 months, and then nightly and during naps until the child is up to 4 years old.
And poor compliance is the biggest cause of relapse.
The single biggest cause.
Okay, let's quickly touch on a few other key foot conditions. Congenital vertical talus, CVT.
This is a rare, severe deformity, often associated with neuromuscular conditions like arthrogryposis. It presents as a stiff rocker bottom foot. The sole is convex, bulging outward because the navicular bone is dorsally dislocated onto the talus.
Tarsal coalition is a common cause of chronic foot pain in school-aged children.
This is a failure of segmentation. Adjacent tarsal bones, most commonly the calcaneonavicular or talocalcaneal, fuse together. It results in a painful, rigid, flat foot and recurrent ankle sprains because the subtalar movement is restricted.
And finally, the osteochondrosis of the foot.
These are localized, self-limiting disturbances of blood supply that affect specific ossification centers. We must know the 3 main ones: Freiberg's, which is AVN of the second metatarsal head; Kohler's disease, AVN of the navicular, typically in younger children; and Sever's disease.
And Sever's is a bit different.
It is. It's actually an enthesopathy of the calcaneal apophysis heel pain related to activity in active preteens. And it's crucial to know that Sever's is often overdiagnosed, as the radiographic appearance of fragmentation is often just normal, rapid apophyseal development.
The principles of upper limb reconstruction focus heavily on function over cosmesis. Radial club hand is a severe presentation of failure of formation.
It involves a deficient or absent radius, a deformed ulna, and often an absent thumb. This condition is a big red flag for systemic disorders, frequently seen in VAC-dural or Holt-Oram syndromes. Management is all about creating stability and function.
Radial narsynostosis, a failure of separation. The radius and ulna are fused.
This results in a fixed forearm position, so zero pronation or supination. And here's a key point for you. Surgical treatment is not aimed at restoring movement. That's generally unsuccessful. Instead, an osteotomy is performed only to change the fixed rotational position, for instance, changing a severely pronated forearm to a more functional neutral position.
And the final upper limb condition, congenital radial head dislocation.
This is typically a posterolateral dislocation, and the critical lesson from the source material regarding management is definitive. Surgical treatment should generally be avoided in children. Intervention often leads to worse long-term outcomes than accepting the fixed deformity.
Shifting to the spine. Congenital vertebral deformities, failures of formation like hemivertebrae, or segmentation like fused vertebrae present immediate risks.
These deformities have a high potential for curve progression, and unlike idiopathic scoliosis, bracing is generally ineffective for congenital curves. The highest risk is associated with the congenital kyphosis, the excessive forward rounding, because the progression can rapidly lead to spinal cord compression and neurological deficit.
The most common type is adolescent idiopathic scoliosis, or AIS, a multiplanar deformity involving that lateral curve, rotation, and the visible rib hump.
And AIS is, by definition, painless. Therefore, pain in a child with scoliosis should immediately alert you to an alternative, often more serious pathology like a tumor, a spinal infection, or spondylolisthesis.
Let's run through those management thresholds as they are key for revision.
Okay, curves less than 20 degrees require observation only. Progressive curves between 25 and 40 degrees are managed with bracing aimed at preventing progression, not correcting the curve. And curves exceeding 40 degrees in a skeletally immature patient are typically managed surgically via instrumentation and fusion.
Kyphosis, or excessive rounding, structurally speaking, is most commonly Scheuermann's disease in adolescents.
Scheuermann's is a structural progressive kyphosis. Radiologically, it's defined by wedging of at least 5 degrees in 3 adjacent vertebral bodies, often with end plate changes called Schmorl's nodes.
And spondylolisthesis, the forward slip of a vertebra.
This is typically due to a defect in the pars interarticularis, known as spondylolysis. We grade the slip by percentage. Most mild slips are asymptomatic or present with mechanical back pain and are managed conservatively. Surgery is reserved for high-grade slips or, most critically, those with progressive neurological involvement.
We mentioned the importance of red flags early on. Back pain in a child is always a serious concern.
It must be treated as a red flag until proven otherwise. While most adolescent back pain is self-limiting and posture-related, you cannot afford to miss the serious causes.
What are those specific immediate red flag signs we need to watch for?
Systemic illness, so fever, weight loss, unrelenting pain, especially pain that wakes the child at night, progressive neurological deficit like weakness or numbness, and a sudden painful spinal deformity. If any of these are present, the patient needs urgent investigation.
This concept that a non-progressive neurological insult leads to progressive orthopedic deformity is one of the most counterintuitive ideas in the field.
It is the central mechanical concept of neuromuscular orthopedics. The brain damage, the insult, it doesn't get worse, but the skeleton does. As the child grows, abnormal muscle pull combined with the forces of gravity exert continuous stress on the growth plates and joints, leading to progressive bony deformity and fixed joint contractures.
So management must be multidisciplinary and long-term.
Absolutely. The primary focus is always on maintaining joint movement and preventing fixed contractures through splinting and positioning. The role of surgery is limited but targeted, restoring mechanical alignment by lengthening tight muscle tendon units, performing tendon transfers to rebalance forces, or in end-stage deformity, performing a fusion to stabilize a dysfunctional joint.
Cerebral palsy, the most common motor disability in childhood, is a non-progressive insult to the brain that manifests as a spectrum of orthopedic issues.
It's classified by the type of tone and the site of involvement. The most common is spastic CP, resulting from pyramidal system damage. You also have dyskinetic and ataxic types. Site classifications include hemiplegia, one side, diplegia, legs worse than arms, and total body involvement, or TBI.
And tone management seems to be the critical first step before orthopedic intervention.
It creates the window. We use drugs like baclofen or focal neuromuscular blockers like botulinum toxin. Injecting Botox into an overactive muscle allows that muscle to relax for a few months, creating a critical window during which intense physiotherapy and stretching can be maximally effective.
For children who are ambulant, computerized gait analysis is key to surgical planning.
It is indispensable for patients with patterns like spastic diplegia, who often develop a debilitating crouch gait. Computerized analysis objectively measures joint kinematics and forces, guiding the planning for single-event multi-level surgery, or SEMS, where multiple procedures are performed simultaneously to maximize functional improvement.
What are the primary orthopedic concerns for children with total body involvement, TBI?
These children are non-ambulant, so our concerns shift to comfort, seating, and ease of care. The two main issues are hip subluxation leading to dislocation and severe spinal deformity. Management is often aggressive, focusing on maintaining hip production to prevent painful windswept deformities.
This section deals with high-stakes, time-sensitive knowledge. Musculoskeletal infection demands immediate recognition and action. Let's start with septic arthritis.
Septic arthritis is an absolute orthopedic emergency. It's usually due to hematogenous spread. It's tricky because its presentation, fever, pain, refusal to move the joint can mimic benign conditions like transient synovitis of the hip. Missing it can lead to lifelong joint destruction.
Why is it such an emergency? What's happening in the joint?
The pus in the joint is toxic. Leukocyte proteases attack and rapidly destroy the articular cartilage matrix, often within hours. Furthermore, the pressure inside the joint capsule can compromise the blood supply to the epiphysis, leading to AVN, particularly in the hip.
We need a reliable tool to distinguish sepsis from transient synovitis. That's where the Kocher criteria come in.
The Kocher criteria give us a predictive probability. You need to know these 4 clinical predictors. 1. History of fever greater than 38.5 Celsius. 2. Inability to bear weight. 3. A high ESR greater than 40. And 4. A high white cell count greater than 12.
And if a child meets all 4?
The probability of septic arthritis is over 90%.
If the probability is high, what's the immediate treatment?
You need prompt joint aspiration followed by immediate formal surgical washout and irrigation to remove the pus. The source material highlights Staphylococcus aureus as the most common bug, but Kingella kingdae is increasingly recognized in younger children.
Moving to osteomyelitis or bone infection?
This usually starts in the metaphyses of long bones because of the looped, slow blood flow in those regions, which encourages bacterial seeding. Abscess formation causes pressure, which destroys the bone locally. And critically, if pus forms beneath the periosteum, the pressure can strip it off the cortex, rendering a large segment of bone avascular.
What happens when the infection becomes chronic?
The body tries to fight back. New bone forms around the site, creating the involucrum, which is a sheath of new bone, and it surrounds the fragment of dead infected bone, the sequestrum. This creates a bone-within-a-bone appearance on the X-ray.
The limping child is a continuous clinical dilemma, requiring the use of the surgical sieve to ensure we don't miss tumors, infection, or trauma. A key to efficient diagnosis is stratifying by age.
Knowing the age-specific patterns is crucial for focusing your investigation. For instance, in a 1 to 3-year-old, you're primarily thinking about septic arthritis, DDH, or transient synovitis.
Then 3 to 10 years old.
Perthes disease becomes the top orthopedic concern, and once they enter the 11 to 15-year window, SCFE is the predominant hip pathology we must exclude.
Our final vital area of awareness in pediatrics is non-accidental injury, or NAI.
This must be in the differential, especially for children under 3, those with disabilities, or those from families facing significant socioeconomic deprivation. Vigilance is key. We must look for specific red flags in the history, a delay in seeking care, a variable explanation, or a history that is inconsistent with the injury.
And the source material provides highly specific fracture patterns that, when seen, make the diagnosis of NAI almost certain.
Yes, these are the pathognomonic findings. Multiple fractures at different stages of healing, meaning new and old fractures coexist. Posterior rib fractures, scapular fractures, and the highly specific corner or bucket handle metaphyseal fractures, a tiny chip of bone lifted from the growth plate, caused by violent shaking or yanking.
So the rule is,
any fracture in a child who is not yet walking must be treated as NAI until proven otherwise. Immediate action, documentation, and involvement of child safeguarding teams are mandatory.
we have completed a comprehensive journey through the immature skeleton. The essence of pediatric orthopedics is captured in that opening thought. Management is fundamentally about leveraging and managing the child's growth. We've learned to distinguish the flexible, transient problems, like the normal progression of bow legs and knock knees, from the life-altering structural pathologies like DDH, Blantz, and SCFE.
For anyone revising this material, focus on the emergencies. That is where the morbidity lies. Know the predictive power of the Kocher criteria for septic arthritis. It demands immediate surgical drainage. And recognize the acute, unstable SCFE as equivalent to a fracture, demanding immediate, gentle, in situ fixation. The unique resilience and remodeling capacity of the pediatric skeleton means that early, correct diagnosis is the single most important action determining long-term function. It ensures that the two laws, Hutter, Volkmann, and Wolff, work in the patient's favor.
We spent a lot of time discussing DDH, noting that the window for meaningful acetabular remodeling significantly decreases after age 3 or 4. This really is the deadline nature of the field. So here's our final provocative thought for you to consider. Given the lifelong cumulative risk of osteoarthritis in patients with residual DDH, and knowing this 4-year developmental deadline exists, how effectively can a universal screening program, which is typically designed to catch hip instability only in the immediate neonatal period, truly capture the total burden of developmental dysplasia that only becomes radiographically apparent years